Welcome to Live Doctors. I'm Dr. Andrew David Schiller. I'm today with Dr. Joseph Alpert, who is a professor of internal medicine, who's a cardiologist. He's a professor at University of Arizona School of Medicine. He's the editor of the American Journal of Medicine. He's had an illustrious career for decades and decades with hundreds of scholarly articles and book chapters. His career has taken him from Yale to Harvard, University of Massachusetts, and now to Arizona, where he's been working for a long time. He's going to talk to us today about myocardial infarction or heart attack. We're here in Tel Aviv, Israel at the site of the International Conference on Acute Cardiac Care. So we're fortunate to have Dr. Alpert with us today. Thanks for joining us.
Pleasure to be here.
Why don't we start by telling our people who are watching at home what is myocardial infarction?
Sure. Well, the lay term is a heart attack. And so what happens with myocardial infarction is, and this, by the way, can happen with any organ in the body, if you cut off the blood supply, it's just like cutting off the gasoline into your car motor. Suddenly, things stop working. So the area that no longer gets blood supply, doesn't get oxygen, doesn't get nutrients, doesn't get food, those cells die. And what happens with a heart attack, patients develop this very common disease called atherosclerosis, hardening of the arteries. And this hardening of the arteries relates to cholesterol and lifestyle. We'll talk more about that in a minute. And what happens is periodically the hardening of the arteries can actually, an area in the artery can actually crack or break. A blood clot forms, blocks the artery, and beyond that blockage, the heart muscle dies, and that's a heart attack. And of course, it's associated with a number of symptoms, which we're also going to talk about. And of course, the good news is that the therapy is very, very effective these days. In fact, when I was a medical student, I like to say in the Middle Ages, about 1/3 of people who had a heart attack were dead in 30 days, and today it's 5%. So it's one of the areas, just like the treatment of HIV and a number of other areas, where there's been just remarkable developments to the benefit, of society.
That sounds good to hear. So I guess we'll hear more about how we deal with heart attacks. So what you're saying, though, as sort of a reassuring thing, is that heart attacks aren't as fatal as they used to be.
Absolutely.
And there's a lot that can be done about it. So maybe we should start by talking about who gets heart attacks.
Right. So it turns out that heart attacks relate to our Western lifestyle. Our ancestors were very active. They had to be, right? They didn't have cars, they didn't have electricity, so everything they did to eat and not be eaten required a lot of energy. Well, you know what we do today. People are sitting around on couches eating potato chips, getting fat, not exercising. Cigarette smoking is a major risk factor for this disease. When people get fat, they get high blood pressure, they get diabetes. You mix all that together, and what you get is high fats in the blood, high cholesterol in the blood. That leads to damage to the blood vessels, the hardening of the arteries process, and leads you down the road towards a heart attack. So it's lifestyle, really, that does it. Now, there's of course, some people inherit a tendency where they much more rapidly get this. For example, diabetes at a younger age and so forth. But throughout the world, this is now the #1 cause of death, and atherosclerosis, or hardening of the arteries, is really universal. In fact, when they've done CAT scans on the 5,000-year-old Egyptian mummies, guess what they discover? Atherosclerosis, hardening of the arteries. So it's been around a long time. And probably the pharaohs or the wealthy people had the same lifestyle that we're just talking about. They probably weren't eating potato chips, but they were sitting around relaxing. They weren't doing physical exertion. They were getting fat and so forth.
In our times, is there particular groups of people by age, by gender, by race that are more likely than not likely than others?
I would say it tends to be a disease that's universal, first of all. Chinese get it, Israelis get it, North Americans get it, South Americans get it. But there are families where you have a history of this, just as there are certain families that have a history of cancer. And in fact, the genomic biologists, the DNA biologists who are now looking at the code in people, have discovered a number of markers that can be inherited that make you prone to this disease. For example, many families, my own included, have a tendency to high blood pressure. Many families have a tendency to high blood cholesterol. So that you could have two individuals eating the same diet, and one that has a family history that the genetics, they're producing lots of cholesterol in their blood, and the other person may not. There are, as you know, differences. Some people get fat very easily. And when people get very fat, that means that pushes them in the direction of developing so-called type 2 diabetes. Not the childhood diabetes, but the adult form of diabetes. That diabetic state damages the blood vessel walls and starts the hardening of the arteries process. Just as having a high cholesterol, smoking cigarettes, uncontrolled high blood pressure, these are the major factors. But what plays into that, of course, is the lifestyle. What are you eating? How active are you? And of course, are you eating a healthy diet, or are you eating a diet that's very unhealthy? And we'll talk a little bit about that later, about what's unhealthy in the diet.
Okay. And so it sounds like, to sum up what you're saying, is there's clearly genetic factors to it, but there's also lifestyle factors. So a lot of chronic illnesses, just like them, it's nature and nurture together that determine.
Absolutely. When I was younger and in school, there were these big debates about how much was nature, how much was inherited, and how much was nurture. I think the nice thing is, it turns out it's complete interaction. The joke I always tell people is, those two snakes entwined on the symbol of doctors? That's nature and nurture. And in fact, we used to think, oh, well, nurture did something, to the body, but the blueprint code, the DNA, was unchangeable. We now know, no, the environment can actually change, as you know, can change the DNA code. So the two are going back and forth, interacting constantly with each other.
So it sounds like one of the messages for somebody who's got a strong family history of heart disease is it doesn't have to happen to you too if you take the right steps in terms of lifestyle.
Absolutely. And the opposite. Even if your family has no history of it, you're smoking 2 cigarettes a day, you're eating all kinds of bad things, you're getting fat, you're not exercising, you could have a heart attack at a young age, even though your family tendency is not in that direction.
Very interesting. Okay, so we've got a picture of who gets heart attacks. And people obviously would want to know, well, how do I know if I'm having a
Heart attack, of course.
So maybe you could tell our viewers, what are the signs of a heart attack? Does it vary between men and women? Does it vary based on other factors?
Yes. So first of all, the usual symptom for a patient having a heart attack is chest discomfort. And I don't say chest pain, because very often, this was one of the things that was taught to me very early in my career. When you and I talk to people about pain, they think of somebody sticking a needle in them or pouring hot coffee on them. But in fact, the discomfort that you get with a heart attack, it's an internal discomfort. So it often more commonly resembles heartburn or indigestion, and it's often a vague symptom, and people have a hard time describing it, because it's not, oh, I just stuck myself with this needle, or oh, I just poured hot coffee on my arm. It's a more amorphous, difficult to describe discomfort, and it usually occurs somewhere near the center of the chest. The textbooks will tell you, oh, it's right here over your breastbone, and then people say, oh, it's like a squeezing sensation and so forth. And many patients have that typical symptom, but many patients have atypical symptoms. It can be on the left side of the chest, the right side. Some people feel it in the neck, in the jaw. Some people just feel it down the arms and the wrist. So any upper, above the waist discomfort, below the jaw and below, so it isn't pains up in this part of the head, but anything from the lower jaw to the belly button can be a heart attack. It turns out women a little more commonly experience this discomfort as indigestion. And that's one of the reasons sometimes in the past, particularly since we've had a lot of campaigns that say, no, this is an equal opportunity killer, women can get it. A lot of times women in the past used to delay. Oh, it's just indigestion. I'll take, some antacid. I'll take some Tums or Maalox. I'll be okay. And in fact, it was actually a heart attack that was occurring. And it's important these days to get to the hospital as early as possible, as you know, Andrew, because we can open up the blocked arteries and sort of stop the heart attack in its tracks. And we'll talk some more about that in a minute. But in any case, the important thing for people to know is that it's usually some sort of chest discomfort, often associated with some shortness of breath, often associated with some sweatiness and a vague sense of great discomfort. The problem, of course, is that either 8 or 10 out of people who have this just discomfort, it's not a heart attack. It's a muscle spasm. It is indigestion and so forth. But there's no way you can tell that when you're at home. So, I mean, of course, if you're 18 years old and you have this, it's not a heart attack. But if you're, 60 years old and you've had some high blood pressure and you've smoked in the past, the place to be if you're having discomfort like that is to come to the emergency room. Get an electrocardiogram, let us decide. If it's benign, hey, you go home. It's a muscle spasm, it's an indigestion. If it's a heart attack, you're coming in so we can do things to stop the heart attack.
Many people hear that the symptoms are different for men and women. Is there something to share that will distinguish that?
Yes. Well, first of all, women can have absolutely typical symptoms. The fist in the chest. By the way, this fist in the chest thing is named for a Jewish physician, Dr. Samuel Levine at the Peter Ben Brigham Hospital in Boston. He was the first person to say this is, and so people will talk about, interestingly enough, I would call it the Levine sign, but they pronounce their name the Levine sign. So this is the Levine sign. He was one of the pioneer cardiologists, took care of Eisenhower when he had his heart attack and so forth. In any case, women can have totally typical symptoms, but women present a little more commonly with what we call atypical symptoms. So indigestion or heartburn, or maybe just discomfort in the arm, in maybe more commonly the left arm. So it is a little more common for women to have atypical symptoms, but many women will have the absolute typical textbook described symptoms that you see in men.
When someone has symptoms that could be a heart attack,
Yeah.
and they're likely to be at risk of a heart attack, they really can't mess around.
Yeah.
Because if they don't get to the emergency room quickly,
Yeah.
they're basically potentially putting themselves at very high risk.
Yeah, think of it this way. You cut off the blood supply to a piece of heart muscle. So the heart muscle starts to die, but it doesn't die all of it instantaneously. It dies gradually, and it takes several hours, sometimes even more, and there's a bunch of factors that actually a lot of research has been done on how quickly does the heart muscle die, how much survives, and what can we do to help it survive longer. A lot of it has to do with control of blood pressure and things like that. So when the heart muscle starts to die, the sooner you get into the hospital, the sooner they open up the artery, the sooner the whole process stops. So the longer you delay, the more heart muscle you lose. And people, for example, there's always anecdotes we tell each other in the hospital. The person who came to visit somebody and starts to have a heart attack in the hospital, and then obviously they get very quickly down to the catheterization laboratory where we reopen the artery, and so sometimes the heart attack is tiny. Even though the original finding on the electrocardiogram, the test that we do to diagnose the heart attack, is, oh, this person's headed towards a big heart attack, sometimes they end up with a tiny heart attack just because they got in early and we got the artery open.
Interesting. So it sounds like what you're saying is there are very good emergency treatments.
Wonderful.
To stop
Yeah.
a heart attack.
Yes.
Someone who would have in the past forget about it, the game is over.
Yep.
They're able to actually even reverse it or stop it from even being a bad heart attack.
Absolutely. And then, of course, what we try and do is get people to change their lifestyle, get their blood pressure under control and so forth, so that we markedly decrease the chance that they're going to have a second heart attack. I always tell my patients, okay, you had this heart attack, we've taken care of this one. The name of the game from here on in is no more heart attacks. And the same thing, by the way, it's the same process that often causes strokes. It's the same process that can cause loss of toes or feet, because of lack of blood flow. So the name of the game is we want the channels open. We want the railroad running. We don't want the train off the tracks.
Right. So one more question, Dr. Alpert, about how to know if a person's having a heart attack. Suppose you're at some friend's house for a dinner party, and whether the person's 18 or 38 or 58 or 75,
Sure.
somebody starts to have pressure or discomfort in their chest, what questions are coming to mind for you that would lead you one way or another to say, hey, this is suspicious, you need to go to the emergency room,
Right.
versus, I don't think this is something to worry about, just stay and enjoy the dinner
Yeah,
party.
good. It's a very good question. So, of course, we can't see into somebody's body, right, like Superman. So I can't tell for sure, but there are certain characteristics of the discomfort. So if the patient is telling me, or the individual at the dinner party is saying, I'm having this indigestion, and also I feel something funny in my left arm, or I have this indigestion and I've got this funny feeling in my jaw, that's very suggestive of heart pain. But if they're telling me, oh, I have this chest pain right there, that's almost certainly not a heart attack.
Very
Specific
narrow,
single area. That's very likely to be a spasm of a rib muscle. It's likely to be possibly a little rib arthritis where the rib bone meets the breastbone. And those things turn out to be more common, fortunately, than heart attacks. But sometimes people will describe it for you. Also, it depends upon who's telling you this. If it's an 18-year-old or a 21-year-old who exercises regularly and feels terrific and so forth, then it's much more likely to be a muscle thing or an indigestion. If it's somebody who has a long history of a hiatus hernia and indigestion and so forth, it's more likely to be that. But we can't be 100% sure. We can be, I would say, 90+% sure in many cases and say, no, this isn't anything. Particularly if I press on the patient's chest, oh, that hurts, right? That's the pain right there. Well, you're reproducing the pain. That's not a heart attack. But if the person's in the right age and they have so-called risk factors, as we talked about, high blood pressure, diabetes, known high cholesterol and so forth, cigarette smoking, then that's a person that probably ought to say, let's go to the hospital. So, I'll give you an example. So, a year ago, I go every January, early in January, to New York City to meet with a group of publishers because of my job as editor of the American Journal of Medicine. I'm one of the judges on the best scholarly books of the year. So one of the fellows there, who I'd known, been doing this for a number of years, I could see he didn't seem very happy. So, I said to him, so-and-so, you look like you're uncomfortable. He says, I'm having this discomfort, or, this pain right here, and, he was, in his 50s. He didn't have a huge number of risk factors, but I couldn't be sure. And I said, you know what? Let's just go off to the closest hospital is the Beth Israel Hospital nearby. Let's just have you get a cardiogram. And he got a cardiogram, and it wasn't totally normal. They actually kept him overnight, and the next day they did this angiogram. It was normal, and so I saw him this year at the meeting. He says, I can't tell you how grateful I am, because of course it could have been a heart attack, and if it had been, I shouldn't be sitting in the meeting. I should have been, doing just what was done. And very often we find that, as you know, that no, it's not a heart attack. Hey, that's good news, Sometimes we also find, though, it's not a heart attack, but the patient already has some atherosclerosis, and that gives us the impetus to say, hey, this was not a heart attack, but you're heading down the road towards a heart attack. We need to make corrections in your lifestyle and your certain things, your blood pressure control, your diabetes control, and so forth.
Let's talk about treatment. When someone is suspected of having a heart attack, they come to the emergency room.
Yep.
What do they do?
Yeah. Well, the first thing we do when people are announced that they're having discomfort, that they might be a heart attack, is they need an electrocardiogram. Sometimes that's done at home. So if you're living in an urban area, and I'm sure here in Israel, where you have this fabulous system of coronary care units and the country is small enough, the emergency medical technicians, the EMTs, actually can take a cardiogram on you right in your own home and transmit it, over the radio waves to the emergency room or to the intensive care unit, where the cardiologist will look at it and say, well, this looks normal. But even if it looks normal, you could still be having a smaller heart attack. So we would, if the story is good and the patient looks like they smell like they could be heading towards a heart attack, we would still have that person brought into the emergency room. But there wouldn't be quite the, all the red lights wouldn't be flashing as much and the sirens wouldn't be quite so intense, as if, oh, wait a minute, this is a heart attack. This is a myocardial infarction evolving, happening right under our noses. Then, of course, we're going to do everything we can to get you as quickly as we can to the hospital. Usually, if it's done by the EMTs, the emergency medical technicians, we'll skip the emergency room. We'll go straight to the catheterization laboratory. But let's say it's less clear. It isn't obvious from the electrocardiogram. And many times it's not quite so clear, particularly in the beginning. You'll stop at the emergency room for another cardiogram. Sometimes we'll even do some blood tests to look for when the heart cells are damaged. There's a release of certain proteins and chemicals into the bloodstream from the inside of the heart muscle, and we can measure that, and that tells us, oh, wait a minute, there have been heart cells damaged here. Even if it's a small amount, it could be sort of like the rumbling of the volcano. You know, there's about to be a huge explosion, but things haven't gotten quite so far.
So that could happen, that there could be release of these proteins proving that there's heart muscle damage, even if the EKG is negative?
Absolutely. We see that all the time. And that's, you know, actually that's good news, because usually it's a little tiny myocardial infarction, a tiny heart attack. But again, again, the volcano example or the iceberg example, right? The part that sticks up above the water is only a tiny fraction of what's under the water. And then so usually when we see that bump and the protein is called troponin, and it's part of the internal structure of the heart that enables it to contract the heart cell. So when we see that in the bloodstream, it means the heart cell has been damaged. Now, what makes it more complicated, and one of the things that's part of my research area, is that you can have injury to the heart without having a heart attack. So let's say you're in a car accident and you bang your breastbone against the steering wheel. You can actually hurt the heart and you'll get a bump in this same troponin value. But that's the job. We're going to admit you to the hospital. We're going to do tests. We're going to figure out, is this a heart attack? Oh no, this is something else. The heart was injured with something else. And when it's injured by something else, for example, a virus in the heart or by hitting the steering wheel, the heart recovers. Heart attack, the heart can recover also to some degree, but it depends upon how much heart muscle you've lost. You lose a great big piece of heart muscle, you're not going to regrow that. So the liver, as you know, the liver is remarkable. You can take a chunk of liver and you can regenerate a whole new liver. And they do that. You know, little kids who need it get a little piece of liver from their mother or their father and they grow a new liver. Unfortunately, the heart's not that good at repairing the damage. So you'll get a small repair, but you're not going to get the complete replacement of the heart muscle. So that's another reason to get in early, so that we stop the heart attack so you don't have a huge amount of heart damage and scar tissue.
So if I understand it correctly, doctors like to say time is muscle.
Absolutely. The time is muscle. Every minute you're losing a little bit of your heart muscle when you have a blocked artery, and we want to open the channel, get the blood flow going back to those heart cells so that we stop the process.
You mentioned earlier that when someone comes to the emergency room or gets to the hospital, if they've got some evidence that they really are having a heart attack, they might not even go to the emergency room.
Right.
They would go to the catheterization lab.
Exactly.
What happens there? What's catheterization?
Sure.
And what is that?
Sure. So cardiac catheterization, cardiac means heart, and catheterization means inserting a small plastic tube into a blood vessel and passing it up into either the heart muscle itself or using it to inject a dye that shows us a picture of the heart blood vessels. It was invented by the fellow my original mentor and trainer, Louis Dexter at the Brigham Hospital in Boston, who did the first heart catheterizations. So the procedure, there's many different forms of heart catheterization these days. The one that would be done on somebody that we think is having a heart attack is called coronary angiography. Coronary means the heart blood vessels, and angiography means taking pictures of the heart blood vessels. And so what happens is the catheter, let's say, is passed from the little artery here where you feel your pulse, or from an artery in your groin, up, and it's specially formed, so it goes right into the coronary artery. We inject this dye that looks clear when you and I look at it, but to the X-ray it looks like milk. It looks white. And we see an X-ray movie, we can actually see, oh, look at that. The artery started here. Oh, it stopped early. It's blocked. So then what they do is they pass a small wire down that artery, and eventually another catheter with a deflated, collapsed balloon, and they open the balloon and it breaks up the clot and opens the artery. And often they'll put a small metal wire stent in there to hold the artery open at that point. And it's usually a point where the atherosclerotic process, the hardening arteries process, has ruptured or in some way torn, so that suddenly the body's clotting mechanism sees, oh, there's an injury here, we have to form a blood clot, just like you get a scab on your skin when you bleed and you stop bleeding.
Very interesting. So in other words, they put the catheter in there, they can take a picture of the blood vessels of the heart, and if one of them is closed, the one that's causing the heart attack,
Yep.
they put the balloon in there and open it up and put in a stent, and that basically can stop a heart attack.
Absolutely. Now, what often happens, of course, is the heart has three main blood vessels. I always tell patients, think of it as you have three lines going from the gas tank in your car and into the motor. So usually patients have just one vessel that's severely involved, but sometimes we'll see patients with additional very severe, what we call high-grade narrowings elsewhere, and sometimes those will be fixed at the same time, or we'll keep the patient in the hospital for a day or two, bring them back, and do the other blood vessels at a later point. If it's very severe and is difficult to get at with angioplasty, we may send the patient for coronary bypass surgery, where blood vessels are taken either from the back of the breastbone or from the leg and inserted into the heart. Sort of like you're going along the highway, there's a bridge over a river, the bridge is washed out, we build a new bypass highway across and connect up so the traffic can keep going. And that's why it's called coronary bypass. It bypasses the area that's narrowed.
Now, is there anything else about this acute management of heart attack that people should know? Because what we've heard about is that if someone clearly is having a heart attack, they go to the cardiovascular, the catheterization laboratory, and they do this test called an angiogram, and so they open it up with the balloon, and if the balloon can't do the job right, sometimes they might need to take him to the operating room and do the bypass.
Absolutely.
Are there other acute management things that would be done instead of that or in addition to that people should know about?
Sure. Well, the last 40 years has seen tremendous development of drugs, of pharmacological products that are given at the same time or even before the catheterization that can help to slow down the heart attack to some degree, and also to manage to help keep the stent or ballooned area open. So there's blood thinners. Because people who have a heart attack at that moment have a tendency for the blood to clot in a blood vessel. So we want to interfere with that. And so usually there are some forms that we give intravenously, that is by injection, during the time that the patients are in the catheterization laboratory. And then there are pill forms that people will take after that to help keep that artery open. There are medicines to help lower the blood pressure. If the patient has too high a blood pressure, you're asking this poor injured horse to run faster, right? So we say, hey, let's quiet the horse down. And there are things that help lower the blood pressure, slow the heart rate down, do a number of things that help to allow the heart to heal. And by the way, a lot of these are things you take after the heart attack because they also help to prevent the next heart attack, which is public enemy number one.
Can you tell our viewers what are the names of some of those medicines that are used
Sure.
to thin the blood during the time of
Sure.
catheterization and
Sure.
then afterwards?
Yeah, so the intravenous blood thinner that's most commonly used for heart attacks is called heparin. And it's actually a natural product. It occurs in our body. It's actually made, from animal products, from cows or pigs when the animals are slaughtered for eating. This is extracted from the intestines of the animals and then cleaned and purified and so forth. And by the way, sometimes even a very Orthodox Jew might get heparin, that's derived from a pig. But as you know, the rule says in questions of health, we don't worry about the dietary restrictions. It's more important to save somebody's life. And so that's the intravenous form. And then we'll usually go to oral forms. It turns out aspirin is a mild blood thinner. So many patients will go home with a small dose of aspirin that they'll take each day. And then there are a number of other drugs. For example, there's one called clopidogrel. The brand name in the United States is Plavix. That's very commonly used, often in combination with aspirin. There are several others that can be used with aspirin, particularly if the cardiologists who are doing the stent are not totally dissatisfied with the placement of the stent. They think, oh, there's an increased risk for a blood clot forming here. They might use a drug called prasugrel or a drug called ticagrelor. But the most common one is clopidogrel, the one that's called Plavix. I don't know, what do you call it in Israel? Is it not called Plavix?
Plavix.
It's called Plavix here too. I think it's pretty much all over the world they call it Plavix. That's the most common one. It's generic. It's not expensive. Aspirin, of course, is very inexpensive. So it turns out, fortunately for patients, that many of the drugs that we use in combination, both at the time of the heart attack and later, are so-called generic. That is, the patent is run out, so the prices are very reasonable. No, I know you have a socialized medicine system here in Israel, so maybe the cost isn't so much. But I suspect there's probably still a small copay. If you're getting one of the newer drugs, the amount you're going to have to pay is probably more than if you're getting a generic. And just about all the drugs are generic, which is good news in the US, where many patients have to pay a substantial portion of the drugs.
Okay, very interesting. So it sounds like the medications that they use before the heart attack or during the heart attack when it's being treated in the hospital are often the same ones as are used after the heart attack when a person goes forward to do that very important prevention of another heart attack.
Yeah.
And that's mainly aspirin,
Correct.
platelets.
We also give drugs to slow the heart rate and the blood pressure, so-called beta blockers. There's drugs that help control the blood pressure and also help to, lead to health of the blood vessel. Those are called angiotensin converting enzyme inhibitors. We call them ACE inhibitors, or angiotensin receptor blockers. We call them ARBs. So how do we know that these drugs help? Well, as you know, these days, the medical education is to teach people to do things according to the best scientific evidence. We call it evidence-based medicine. So when I was in training, much of what I was taught we call eminence-based medicine. Do it because I tell you so, because I know. And that's based on experience, and many times it's right. But in fact, as you know, science keeps moving. So I have a lecture that I love to give called All the Things I Learned in Medical School That Weren't True. And there's a lot of them. And there's also a wonderful story, I hope it's true, of a dean of one of the Chicago medical schools who on the first day of class for the students comes in and says, here's an important lesson. Half of what we're going to teach you is wrong. We just don't know which half. So, medicine constantly moves. And there are these, what I call the gold standard randomized big trials, where neither the doctors nor the patient know who's getting the sugar pill, the placebo, and who's getting the active agent. When they break the code at the end, they may discover, wow, this drug really worked. Just as often they find out, oh, this drug didn't work. But all the drugs that work get a special gold stamp, if you will, both from the European Society of Cardiology, the Israeli Society of Cardiology, American College of Cardiology, American Heart Association. These are the drugs that have been proven by science to help you. Now, we can't be sure they're going to help you, but the odds are that they're going to help you.
Let's talk about that just a little bit, because what does it mean when a study says that the drug worked?
Yeah.
Does that mean it works in a certain percentage of people?
Yeah.
And like what percentage? So, if there's 100 people in a room,
Yeah.
how many of them need to get benefit for
So-
it to actually say the drug helped?
Right. It's a great question. So when we do the randomized controlled trials, of course, there's always somebody who's an expert in statistics, a biological statistician. We call them a biostatistician, who's involved with the trial. And at the end of the trial, they apply a lot of very sophisticated mathematical analyses. And you can predict, yes, it is likely that more patients benefited in this than did not benefit. But it isn't 100%. No drug benefits 100% of the people. So it would be a good drug if it benefited 55% or 60% of the people, and 45% it didn't benefit. Now, sometimes we can predict who's more likely to benefit, because when they look at the trial, they say, oh, this drug was better in people with X or Y or Z. But again, what it really is like, Andrew, it's a horse race. So you go out to the track, you take your money, you can bet on the 100-to-1 long shot. That means the horse has one chance in 100 of winning, or you can bet on the 2-to-1 favorite, right? Well, I always tell my patients, bet on the 2-to-1 favorite, because betting on the 100-to-1 long shot, you're probably going to lose your money. And it's the same thing with the randomized trial. It says that there is a good chance that you'll be the favored horse if you take this drug. But it's not a guarantee, because sometimes, as you know, the favorite loses, but we can't know that before the horse race.
Right. Okay. So it's a very nice overview of how we treat an acute
Yeah.
attack of myocardial
Yeah.
infarction.
And by the way, we do that throughout medicine, because the randomized trials are there for liver disease. They're there for ulcer disease. So that we always take this and we tell the patients, this medicine has been shown to be effective to help you. I can't guarantee it's going to help you, but it makes you the favored horse as opposed to the long shot. Yeah, you want to keep smoking, you want to eat horrible foods, you want to get fat and don't exercise, you're making yourself the 100-to-1 long shot to win the race. If you do all the things we talk about, you're making yourself much more likely to win the race.
Very interesting.
Or as I say, be around to see your grandchildren graduate from high school.
Now, are those two separate categories? Do you think differently about someone who had a heart attack before versus someone who just has risk factors when you're thinking about prevention?
Yes, well, when we talk about prevention, you're absolutely right. There are sort of two forms. There's primary prevention and there's secondary prevention. Primary prevention means you haven't had a heart attack or you haven't had other manifestations of narrowing in the blood vessels in the heart. For example, the so-called angina, the chest discomfort that comes from exertion because the blood vessel isn't totally closed, but it's severely narrowed, and you're asking the heart to work harder, but it's not getting enough blood flow. That means you already have the disease. You have the disease, we then want to prevent you from going on to develop a heart attack, so now we move into secondary prevention. It turns out the treatments are the same, that what prevents the atherosclerosis also helps to decrease its progression, it's getting worse, and the cracking or tearing of that atherosclerotic part of the artery leading to a blood clot. And there are things like...
I just want to make sure I understood you correctly.
Yes.
So it sounds like whether we're talking about primary prevention for someone who's never had a heart attack,
Correct.
or secondary prevention for someone who has had a heart attack, the strategies are the same, but
Yeah.
the sense of urgency and importance might be different for someone.
Absolutely. And so, for example, if I were seeing, these are typical patients. I see a patient who comes in and says, my father had a heart attack at age 55, and my brother has high cholesterol. And we would check the cholesterol and we would check their blood pressure and talk to them about regular exercise, eating right, not smoking, and so forth. That would be a typical primary prevention person. There's no evidence that they already have the disease. On the other hand, the person who's already had a heart attack, we know they had the disease. So we're going to be perhaps even more aggressive in that person because we don't want to prevent the process from starting, or we want to hinder it from getting started. The other person, we know it's there, and we're hoping even with some of these therapies, we can pull a little bit of that cholesterol stuff out of the artery wall and markedly decrease the chance that they're going to have another heart attack.
Very interesting. Let's talk about prevention. What do we do?
Okay, so number one, public enemy number one, cigarette smoking, okay? I notice that message has gotten around pretty well in the US, not so well here in Europe, and not so well in Israel. I see a lot of people, and I was just recently over the vacation, a week in Paris with my family, and I saw lots of people walking on the street with cigarettes. It is a guaranteed way to accelerate this atherosclerotic process. By the way, there's a long list of other horrible diseases. Lung disease, which by the way is a terrible way to die because it's like drowning all the time. You're short of breath all the time. Terrible cancers and so forth. I've had friends dying from lung cancer who were smokers and so forth. So cigarettes are the absolute worst thing you can do. So that's number one. Number two is high blood cholesterol. And you may have a family tendency in that direction, or it may be the result of you're eating a very unhealthy diet, a diet very high in simple carbohydrates like sugars or flour, a diet that doesn't have much fruits or vegetables, a diet that's full of very high fatty substances. Often that makes you fat, number one, pushes you in the direction of diabetes, and also pushes your blood cholesterol up. One of the nice things about being here in Israel, people eat a very healthy diet. Of course, you have a fabulous agricultural system here. So the stores are full of fresh fruits and vegetables. almost all of the big population studies that have looked at what correlates, what kind of diet is the best diet for people, and this is also for preventing some kinds of cancer like colon cancer, it turns out a diet high in fruits and vegetables, a diet low in refined sugars, so lots of sweets, and a diet low in red meats tends to be what comes out. And by the way, nuts and also fall into a good category. So all kinds of nuts. And if you're going to eat breads and so forth, the more fiber is in them, the more whole wheat they are, turns out to be better.
Okay, interesting. And now people talk about things like the Mediterranean diet.
Sure.
Has that actually been established and proven to help with cardiovascular disease? And what does that mean?
Sure, and that the answer to your question is yes. So there were studies both in southern France, in Lyon, France, and there was a study in Barcelona where actually the data that came out of these population studies, which is not as it's suggestive, but it's not absolute proof, where some people were put on the Mediterranean diet and some people were eating, half an inch of butter spread on their bread and so forth. And it did show decreased numbers of heart attacks and strokes in the people who followed the Mediterranean diet. So what's the Mediterranean diet? It's the Israeli. Well, you're here on the Mediterranean. It's what you're eating in Israel. It's lots of salads, lots of fruits, nuts, some seafood, not big portions of red meat, and not a lot of what my wife likes to call sugar-rated. In other words, crawling, way too sweet sugars. My wife is Chinese, and the Chinese tend to overdo it with salt, but they way underdo it with sugar. So she'll taste something, she'll say, this is way too sugar-rated. It means she's right. It's way too much sugar in there. And that's sugar and simple carbohydrates like white flour actually very rapidly push people in the direction of obesity, of getting fat, and also the direction of diabetes. So that's why we like whole grain things like pumpernickel bread and whole grain breads and cereals that have lots of fiber in them. But also what's been discovered in the last 15 to 20 years is less carbohydrates. And the carbohydrates, those are the simple, that's sugars, or simple carbohydrates, sugars and white flour, things like that, as opposed to the complex carbohydrates, which are the ones found in vegetables. Those tend much less to push people in the direction of diabetes and obesity.
We're talking about diet, and you mentioned a lot about simple carbohydrates like sugars and flour and things like that.
Right.
Now that sounds like it's different from when I was coming up in medical school. We talked a lot about fats being the enemy, and now you're talking about carbohydrates being the enemy.
Yeah.
Are you still concerned about fat consumption? Are there good fats and bad fats?
Yeah. Excellent question. It is true. So the American Heart Association, when you and I were in medical school, said, you got to reduce the fat in your diet, and if you're going to have fat, you need plant fats. So they were saying, you should eat margarine, don't eat butter. Well, subsequent science has shown us that's a little bit true, but not as true as the simple carbohydrates. The simple carbohydrates have now moved to be the worst thing in your diet. Yeah. So, the kids who are drinking sodas with lots of sugar, the kids who are eating candy bars all the time, those are really bad for you.
Sounds like Wonder Bread's not so good either.
No, Wonder Bread's not so good. What we want you to do is go to the bakery and buy the whole wheat bread that shows all the nuts and the various fiber and so forth in there. The problem is, of course, fats are still a problem, and it's particularly animal saturated fat from red meat. So that's why we say, if you're going to eat, and of course people will eat for protein sources, flesh, unless you're a vegetarian, it's better to eat the white meat of chicken and particularly seafood and particularly fish, and particularly ocean fish turn out to have a fat that actually can help decrease the cholesterol levels in the blood. So you combine a diet that has lots of seafood and some vegetarian meals and lots of fruits and nuts and vegetables and whole wheat grains and nuts and so forth, and not so many candy bars and simple sugars and sodas and all of those things. Those are really not good for you at all. I call them empty calories. You get calories, but they're not doing you any good. They're just pushing you in the direction of becoming fat.
Very interesting. So the interesting discussion about diet and how it impacts and potentially promotes or can prevent heart disease.
Yeah.
What about other lifestyle factors? For instance, mind emotional factors, stress, these
Sure.
like type A personality and
Yeah.
hostility and cynicism.
Yeah.
Are those things still considered to be important, and what can a person do about that?
Yeah, and in fact, there's actually a special form of a heart attack that can just come from terrible news. We all hear stories about, oh, so-and-so heard that their family member died and they had a heart attack. And that can actually happen. It doesn't happen very often. Usually the heart attack is caused by the hardening of the arteries and all the things we've already talked about. But occasionally people, even with normal blood vessels in their heart, will have a heart attack just from terrible stress. You release adrenaline, into your system, and it causes damage to the little tiny blood vessels in the heart. So stress is a factor. It used to be taught, again, when we were in medical school, the hard-driving executive, the so-called type A, who's always working, is a high risk for a heart attack. Turns out that's not quite true. That personality is not a high risk for a heart attack. The person who's high risk for the heart attack is the person who's angry all the time, the person who's hostile, who's saying, oh, I hate this person and I hate that and nobody ever does anything good for me and I'm so angry all the time. That's the kind of person that's at high risk. We think that's a characteristic that results in a lot of release of adrenaline into the system, and high levels of adrenaline can damage the blood vessel wall. So that's the personality that does that. We actually recommend, as part of our cardiac rehabilitation programs, that's the helping patients with a program after they've had a heart attack. Often we work with them on stress reduction methods, and it'll vary from person to person. Some people, regular exercise is a stress reduction. Some people meditate. Other people do the Asian exercises like Tai Chi. There's a whole variety of stress reduction methods. The one stress reduction method that's not good is cigarette smoking.
Right. Many people these days are really into nutraceuticals and vitamins and extra nutrients. Are there any solid things you can say either for or against things like that for people trying to prevent cardiovascular disease and heart attacks?
Yeah. Well, if you're eating the typical Israeli or healthy American diet or the Mediterranean diet, you almost certainly don't need a vitamin pill because you're getting lots of vitamins. A lot of the vitamins come to us from fruits and vegetables and nuts and so forth. But the vitamin pill almost certainly won't hurt. In most instances, it just passes through the body out in the urine, and as a friend of mine said, you're making expensive urine. But the vitamin pill is probably no harm. Unfortunately, there are lots of unproven products that are sold. Some of them are traditional Chinese medicines. Some of them are Indian Ayurvedic medicines. The problem there is that there's no quality control. And in fact, some of them are adulterated with pharmaceuticals, actual drugs. Some of them have not been cleaned and they have heavy metals like lead, so they're actually poisonous. And the medical literature, as you know, is full of reports of bad things that have happened from people who are instead of going and talking to their doctor and their nutritionist about what has been proven to be helpful, unfortunately they go to the health food store where there's a high school graduate who's just talked to the person who's the detail man that's selling these things and selling them a lot of products that are probably not going to do them any good and may do them some harm. There are a few that have been shown to have some benefit. For example, fish oil. Fish oil is just like I said before, eating fish helps, but fish oil capsules give you that good fat. And by the way, fish oil capsules ought to be kept in the refrigerator because if they stand out on the counter, they can lose some of their properties that are beneficial. Another thing is something called CoQ10, which is actually a normal enzyme, a cofactor or a component of chemical reactions, biochemical reactions in the body. And there haven't been the big, large, randomized trials that we would like about that, and I can tell you the reason for that in a moment. But there's a lot of smaller trials that are suggestive that that might be beneficial to people who are very high risk for heart attack or who've already had a heart attack. The disadvantage is they're expensive. So why don't we have a big trial with coenzyme Q10 or CoQ10? The reason we don't is because it's generic. And usually the big trials are funded by the pharmaceutical companies that have the patent on the drug, because these trials cost hundreds of millions of dollars. Well, you're not going to get somebody who runs a generic company to invest hundreds of millions of dollars in a CoQ10 trial. Why? Because the factory down the street, if the trial's positive, they're going to be manufacturing CoQ10 just like you are. So a lot of these products will perhaps or very likely never be adequately tested. Sometimes the departments of public health, the science departments in Israel, the US, and Europe, and so forth, will fund trials with some of these, but it's only a tiny fraction of the number. So then you're dependent upon, for example, in the Chinese tradition, which I know a little bit about, this herb has been used for 5,000 years to treat X or Y or Z. And it may have an ingredient in it that helps, but the scientifically based medicines that we've got now really are much more powerful at helping you than that herb. And there can be interactions in the body with these herbs. So, I know of patients, including one in my wife's family, who was taking both the Chinese medicines and prescribed medicines and had a very bad reaction, almost died, from that. So we say to those family members, you can take Chinese medicines, but no Western medicines. You take Western medicines, there's no Chinese medicines, because the Chinese medicines are potent chemicals, and so you don't want to mix them in with the potent chemicals that we're giving you unless we know which ones are safe. And really, we don't know the scientific evidence that tells us which ones are safe.
We talked about nutrition. We talked about stress and mental stuff and emotional stuff. What about exercise?
Well, I'm a huge believer in exercise, and so I have to tell you, as a potential conflict of interest, I think it is just as important as your medicines. So I tell my patients, exercise is very simple. Only exercise on the days that you eat. So then they say to me, that means every day. And I say, exactly right. I said, of course, if you have terrible flu and you're in bed, you're not going to exercise that. But every ordinary day, you need to do exercise. I'm not telling you to go to the gym and lift 200 pounds of steel and turn yourself, into a super athlete. I'm saying you need to do every day 30 to 45 minutes of a brisk walk, going on your bicycle, going for a swim, or going to the gym and doing one of the machines and so forth. Depends on the weather, depends on your situation and so forth. But you should exercise every day. And I do it. I do an hour and a half every single day, some days 2 hours. My wife does as well.
That's wonderful. What does that do for a person? How does that help?
Well, we could spend the next hour talking about the benefits of exercise. Let me give you an analogy. 10,000 years ago, our DNA was the same as it is today. There were no cars, there was no electricity, there was no running water. Everything had to be done by hand. And if you wanted to eat, you either had to grow your food or you had to catch your food. And if you go back even a little further, you had to be careful that you didn't become somebody's food. So there was constant activity. Well, think of the lifestyle today, right? We take the car 2 blocks, or at least Americans do, they got to run an errand. Or, they're sitting on the couch, all evening eating, bad foods that are heavily sugar or simple carbs, getting fat, and they're not exercising. So our DNA, our heritage has built into it, because it was from our ancestors from tens of thousands of years earlier, that we need to be active, absolutely active. And there's all kinds of scientific information. It's the one area where every study is positive. Every study of exercise is positive, whether it's really where you have a control group or whether you're looking at population data and so forth. Regular exercise is absolutely essential. And again, it doesn't have to be Olympic style training. You don't need a trainer, but perfectly adequate is 30 to 40 minutes of brisk walking a day. Right here, of course, we're on the beautiful Mediterranean. Right in Tel Aviv, you have the most beautiful place to walk. And I see lots of people out walking and jogging and so forth. And I think that's absolutely an essential component. And it is synergistic. What does that mean? It means it magnifies the beneficial effects of the drugs. So if you have atherosclerosis, exercise on top of the drugs is very important. And cardiac rehabilitation programs, secondary prevention programs are very strong in emphasizing regular forms of exercise.
Interesting. What would you advise somebody who, say they had a heart attack a few years ago, and they weren't so motivated, they were a little depressed afterwards, they went home, they sat around a lot. they've been reading, and some of the family members nagging them, they should start exercising.
Yeah.
Should they just start exercising? Should they get checked out? What should they do? Do they need a stress test first?
Well, we used to recommend that they get a stress test, particularly if there are any disquieting symptoms like climbing a flight of stairs makes them very short of breath or gives them chest discomfort. What I tell my patients is if they say they're not having any chest pains, it looks to me like the heart attack is well healed, I say start gradually. First of all, get good shoes because we don't want you to have orthopedic problems and then say, oh, the exercise was terrible because I hurt my feet, I'm not going to do this. And then start a walking program or get a stationary bike. And the first days, walk 10 minutes at a leisurely pace, and over a period of a month, build yourself up. If you're very concerned, of course, you should be doing this in conjunction with your doctor, and the doctor, or your nurse practitioner may recommend an exercise test so we see what your heart does, that they're not dangerous electrical short circuits and that sort of thing. But often, if you've had a heart attack, a lot of that has been done at the time of the hospitalization or shortly thereafter. But it is important not to say, okay, I'm going to exercise today, I'm going out and I'm going to jog 5 miles. That's a very bad idea. Even if you don't cause some problem with your heart, you're going to be hurting, you're probably going to have tendonitis and arthritis and so forth the next day. You're going to say, oh, this was a terrible idea. So start gradually and build up. And this is true even if you're 80 years old. We now know that older people need exercise as much, if not more, than young people because you tend to lose muscle. And the best way to fight losing muscle and getting weak so you fall and break your hip is to start doing some exercise. Again, maybe not the same level of exercise you did when you were age 40, but it's very important. And I see here on the water, on the oceanside walk, lots of 80-year-olds out there walking, sometimes with a cane if they're, have arthritis. I tell my patients, absolutely, the best thing you can do, besides taking your pills and stop smoking.
Right. Do you have a case or a story or two that might be inspirational?
Yeah.
Someone who seemed like, forget it, this person's done, and they somehow came back.
Yeah, let me give you an analogy. So again, when I was a medical student, as I say, in the Middle Ages, patients would often get 3 to 6 weeks of strict bed rest because it was thought the heart was like tissue paper. Oh, you could tear it and die. And in fact, 1/3 of people did die during that first month. And so gradually we realized, and partly because of people like Samuel Levine and Paul Dudley White, both in Boston, one at the Mass General, one at the Brigham, it was realized that exercise was actually a good idea, but that it had to be, gradually assumed and so forth. So in those days, patients really went home and just sat around waiting, there's going to be like a lightning bolt and I'm going to be dead. And of course, it did often happen like that. What has happened over the years is now I tell patients, I have individuals who survived 20 and 30 years and 40 years after a heart attack, and they're still doing great. But it wasn't the people who did all the wrong things. It was the people who got what a friend of mine calls the cholesterol religion, woke up and said, no more cigarettes, I'm going to start eating right, I'm going to start exercising regularly, I'm going to take my medicines, I'm going to go to the doctor regularly to be checked to make sure that there are no warning signs here that need to be taken care of. So I had one man, I remember this very, very clearly. This was when I've been now 25 years at the University of Arizona. And within the first year, a man came in who was a diabetic and had been a cigarette and was actively still smoking. And he had a substantial heart attack. He hadn't come in right away when he was supposed to come in. He had thought it was indigestion or arthritis. So he had a significant injury to his heart. So his heart function was substantially reduced. And I remember talking to him, he and his wife were tearful, well, this is the end. He was a, fella in his early 50s. So just in the last 6 months, he died at age 85, okay? He had done perfectly the whole time. He didn't have heart failure symptoms. He was playing golf. He had a wonderful lifestyle because he stopped smoking. He lost weight. He exercised regularly. He actually had a tendency to be very anxious and nervous, so he used to do daily meditation. He did all the things that are recommended. And he lived for 35 years after a substantial heart attack. So the message is, it isn't like cancer that's riddled throughout your body, get your will and start buying your cemetery plot. You have a heart attack, there's a lot you can do so that you can live a long time and see your grandchildren graduate from high school, graduate from college, get married, and maybe even see your great-grandchildren. So it's not a hopeless thing, and especially these days, it's definitely something that with all the scientific medicine we have, you really can have a nearly normal or essentially normal lifestyle.
One last question would be, what seems to be on the horizon in terms of research, either for acute management of heart attacks or lifestyle management and prevention?
Yeah. Well, I think, of course, the lifestyle keeps being evaluated constantly, but I think it's probably settled into where it's going to stay. But there are new pharmacological agents, new drugs all the time, new stents, to open up the arteries, and new approaches to doing it, new technology with little drills and all kinds of things that are going to be, they're going to enable patients who have very far advanced disease to actually get to the point where their quality of life is quite good, where their heart disease is not bothering them. So there's a lot of money being invested by industry in this area. No surprise. It's the number 1 cause of death in the world, so industry realizes this is not a rare disease. We're going to be able to sell this to a lot of people. It's going to be a good idea for them if we can prove that it's helpful. So there's a lot of development that's going on there with new drugs. One of the areas that's of most interest, and it's I told you my wife is a basic scientist, very interested in what the heart cell does itself to protect itself. And of course, cells do that. They have whole biochemical machinery when they're being, potentially threatened, that they will kick on that biological machinery to help prevent cell death. And so we're looking at lots of different pharmacological drug products that would help that. It turns out, by the way, the one that she's particularly interested in is revved up in cells by broccoli. So don't do what former President Bush said and don't eat broccoli. Eat broccoli because it actually revs up some of these protective factors within the cells. So it's a good idea to eat broccoli. But that's just a little bit of a funny example. But a number of companies are working on drugs that will do that will enable the cells to resist the fact that they're not getting enough blood flow, at least for a while, and therefore diminish the amount of injury that occurs when a heart attack starts.
Well, thanks so much for being with us. It's really been very interesting and inspiring. We're live doctors, and we've been sitting with Dr. Joseph Alpert, who's a professor of cardiology and internal medicine at University of Arizona, who's been kind enough to spend some time with us teaching us about heart attacks, myocardial infarction. So thanks very much, Dr. Alpert. I'm your host, Dr. Andrew David Schiller, and thanks for tuning in.